Thank you very much for inviting me to speak at the Indian Association of Physical Medicine and Rehabilitation, the Kerala branch. Today, my name is Faux. I'm a rehabilitation physician from Australia, and I'd like to talk about pain management in amputees. This is just to keep you awake, because sometimes my talks can be very boring, but I hope this one won't be. So the approach to post-amputation pain, the first thing is you have to take a history, and you have to remember the phantom sensations occur normally. Unfortunately, they're often associated with falls because people don't know that they don't have a leg there and they fall out of bed. Phantom limb pain was described in 1552 by Paré, one of the famous surgeons during the Franco-English War, and he noted that the pain came on about a week or so after the amputation, and that there was more of it. It's usually intermittent, but it can be prolonged. There was more of it if there was stump pain or spinal disease or cerebrovascular disease, and the rate, the most common rate is about 64%. We're also going to talk about stump pain, both nociceptive and neuropathic, and referred pain. So let's just start with stump pain. Stump pain means pain felt in the residual portion of the limb or stump. Somatic stump pain usually resolves as the wound heals, but people describe stump pain about 57% of the time straight after the operation. It drops down to about 10% at 2 years. It can trigger phantom limb pain. So if the stump pain is very severe, if there's an infection, phantom limb pain can re-emerge or emerge more strongly. And prolonged lump pain usually attributed to local pathology. So you need to have a look at delayed wound healing or infections or surgical complications or poor prosthetic fit, neuromas or adherent scars. And late onset stump pain can come on from neuromas or the prosthetic fit, claudication, bony overgrowth of the end of the stump, osteoarthritis, tumour occurrence, or stress fracture. Stress fracture is important to remember because these bones generally tend to be osteoporotic. Phantom sensations are almost universal. They are also found in people who are born without limbs. And they can be very important psychologically to amputees. We also notice that the sites of the phantoms are variable. So if you have it in the upper limb, you can get pain in your chest, and if you're in the lower limbs, you can get it in your back as well as your missing leg. There are non-painful phantom sensations of three types. They're called kinetic sensations or movement. They can be kinesthetic, which is the shape or positioning of the leg. So some people feel that they can feel their missing leg, but it's shorter. And sometimes it's exteroceptive, so you can feel touch or pressure or vibration in the missing limb. It's most prominent immediately after the amputation and gradually fades over time. And it's often felt to fade or change in a telescopic type fashion. It can persist indefinitely, and it doesn't require treatment, just education and reassurance. While phantom sensations can be the tip of an iceberg, sometimes it's just an iceberg itself. So we're now going to talk a little bit about phantom limb pain, and I'll go into it in more detail as we go. It's described as a painful sensation perceived in the missing limb after amputations. Phantom pains are often described as crushing or twisting or neuropathic, so burning or tingling, and they tend to localise to the more distal aspects of the stump, fingers or toes. And in the early stages, they're quite common, 60 to 80%. The occurrence of phantom limb pain is independent of age. It's independent of gender. It's independent of race or other health status. It's independent of the cause of the amputation or the level or side of the amputation. Brosman showed that phantom limb pain is most common at about 6 months. It's more likely in women, which is why in the previous slide I said it's not really related to gender. It seems to be more likely in upper limbs or early post-operatively. It's less frequent in males, but it's only tiny bit less frequent in males. 66% of people with phantom limb pain use their limbs for more than 4 hours a day by 1.5 years. Paraplegics and diabetics can also feel phantom limb pain, although far less. Diabetics because of the effect on the nervous system, paraplegics because of long-standing effects on the spine. The worse the pain is before the amputation, the worse the phantom limb pain is after. So it usually comes on within 3 to 14 days after an amputation. So if you see somebody straight after an amputation, sure, bottom line is they're most likely not to have it. It'll occur in the first week or two. And then it tends to increase in its frequency and severity to about 6 weeks. And then it diminishes in severity and frequency over time with a resolution over several months or 2 years. However, the rule of thumb is if it's still present at 6 months, it's probably going to be permanent. The duration of episodes vary, so occasionally people have it continuously, but that's a small proportion, only about 12%. Some people have it for days, they'll have days of bad ones, but most people have it hours or seconds. Stump pain intensity tends not to correlate with phantom limb pain intensity. So if the stump pain is very severe, it doesn't mean the phantom limb pain is. So that's the rule of thumb. If it persists longer than 3 months, it's probably going to remain. Treatment is considered very difficult. Probably less than 10% have persistent and severe pain. That doesn't mean you don't have to treat the people with persistent or severe pain. Of course you do. Long-term phantom limb pain, however, is mostly intermittent. Most patients do not require any medication and tends to get worse with fatigue or stress. So in a diary study of 89 people aged 40 or above, pain was variable in intensity. It was episodic in nature. It affected coping skills. And what you see now is not a reflection of what occurs. So because this is a diary study, these reports may not have been reflective of what happened to the pain over time. So why does phantom limb pain occur? Sometimes there's peripheral neuropathic mechanisms like nerve injury itself, which sends aberrant and erratic discharges. Sometimes there's local nociceptive substances, so if there's a lot of inflammation or cytokines. Sometimes we get what's called deafferentation pain, so when a nerve's cut, some of the myelin dies back and then the axon dies back. Occasionally the end of the nerve, the cut nerve, forms into a neuroma, which can be very tender and cause irritation. And there is also some discharges between the sensory and sympathetic nerves that go backwards, back out to the periphery rather than up into the central cord. But you have to be careful. It can be a monster that will come up without you being aware. So you need to know why it occurs. Sometimes there's a spinal cord has been described as developing receptive fields. So what happens is that the nerves come up and tell the spinal cord of a loss of sensation in particular areas, but that spreads over a large portion of the cord, and that can give abnormal sensations in the area of the limb. Sometimes it's central sensitization, which you know about. Sometimes it's an inability to disinhibit emphatic firing of the nerves from the brain. And there are interesting studies on cortical engrams that generate pain in the absence of stimuli. And there's been some cortical reorganization, which I'll show you a little bit about. So in these early fMRI studies, they had 12 people, 6 had phantom limb pain, all had, of the 6 who had phantom limb pain, all were given brachial plexus blocks, which meant that there could be no feedback from the missing upper limb to the brain. And about 3 out of the 6 people had their phantom limb pain completely abolished by the brachial plexus block. The implication here was that it was coming peripherally. However, and those 3, the 3 who had it completely abolished by the block, had changes in their somatosensory cortex. So if you have a look here, you'll see that the hand and the arm is here, but it's quite next to the lips and face. And what happened was the lips and face extended and took over the hand area. So in 2001, they did try some motor cortex stimulation to stop phantom limb pain, and that did stop phantom limb pain in about 2/3 of those with upper limb amputations in that study, implying that it was central sensitization and the pain was being generated centrally, not coming peripherally. So there's clearly a lot to unpack here. Some of it's coming peripherally and some of it's coming centrally. In 2012, they took 18 amputees and age-matched controls, and they remapped their cortexes, not dependent on the phantom limb pain. But what they found is that if they stimulated the leads to the expanded activation centre at M1 and S2 in the brain, there was a greater activation of the ipsilateral S1. So I guess essentially what they were saying is if they stimulated the stump, there was a remapping of the homunculus, which meant that the sensory feedback coming from the limb was being reorganised in the brain. So there are non-neurological factors. So skin blood flow and muscle tension can also cause pain in the limb. And there are psychological factors such as stressors, depression, anxiety, and poor scoping skills. People with perfectionistic or narcissistic or obsessional traits in their personality tend to have a more difficult time with chronic pain. So what we can see is that the homunculus here have afferents from existing parts of the somatosensory cortex of the missing limb, but there's changes that occur there. Then the brain, with the peripheral nerve cut, it'll go up to the into the spinal cord and then all the way up to the thalamus and then to the sensory cortex. And there are a whole variety of treatments here, including opioids and cannabinoids, but there's also non-pharmacological treatments such as mirror box and music therapy and hypnotherapy. Once you get into the spinal area of the neuropathic pain, opioids, antidepressants, anticonvulsants, and some NMDA blockers such as ketamine can be helpful. And then when you get to the very periphery, local anesthetics and antidepressants and anticonvulsants and anti-inflammatories can help. You can use TENS in the periphery, and you can use prosthesis biofeedback to tell patients when the limb is being properly fitted into the socket. If we think about stump pain, which is sometimes called residual limb pain, pain is felt in the residual portion of the limb or stump. It's a somatic pain and it usually resolves. About 5 to 10% persist, and it can trigger phantom limb pain. And I have shown you this slide before to just talk about that. There are other causes of stump pain. One is ischemia. If the amputation's been performed because of ischemia, you need to be mindful of the fact that you can have ischemia in the stump, and you can get like a sort of claudication process. And quite often there are requirements to do re-amputations. or what I've termed as filleting, where you go back and keep cutting back on the limb to get a better area of better blood supply. Sometimes there's a neuroma, and I'll talk about the diagnosis for that, and you can use injections. Botulinum toxin has been used, although it's uncertain how that works. And prosthetics can be amended so that you don't put pressure on the neuroma. And there's also surgical techniques that can decrease the incidence of the neuroma, and I'll come back. You need to examine the stump for allodynia, which is abnormal sensations of light touch. And sometimes that means there's been spinal referred pain, and you can trial a periradicular block or surgical treatment if there's a big disc compressing a nerve root. So sometimes the only presentation will be stump pain. You need to check for infections, particularly osteomyelitis, and I put that here because just to warn against those people who are thinking about interosseous integration, that's only for very small numbers of people because of the high risk of osteomyelitis. You also need to look at the skin. Is it psoriatic? Is there evidence of poorly fitting prosthesis? Complex regional pain syndrome has a number of criteria, including pain, pseudomotor changes, and there is no evidence for any treatment of that condition, particularly not with dorsal column stimulators. And of course, you need to exclude a fracture. It's because it's non-weight bearing most of the time, the bones are generally osteoporotic, and you need to check the stump size for edema, and of course check the prosthesis. That's most important. So in the early phases for the treatment, you need to use non-pharmacological or medical, surgical, and medical and surgical treatment. You need to prevent contractures, limit edema, adequate post-operative analgesia, and patients can learn to desensitize their stump through massaging or bandaging. And the idea is to get the patient moving pretty early and using their prosthesis as early as possible. The treatment is sort of non-pharmacological, so you can use psychological techniques and exercise, simple analgesia, paracetamol, non-steroidals, or if it's neuropathic, you can use anti-neuropathic medications, with opioids the last resort. And that's, if it's the last resort, then you don't you want to be able to navigate back to areas of greater need and greater treatments. So if we look at the neuromas, the pain's usually localised. It's sharp and shooting. There's a Tinel sign. It's reproduced by local palpation, and it's relieved by local anaesthetic injection. Have a look at the socket relief and make sure that if there is a neuroma, that the socket is relieved in that area so that there's not permanent pressure on it. And you can use local steroids and local anaesthetic injections. Ablation with radiofrequency or phenol does not work. Surgery, every time you cut off a neuroma, there's a reasonably high risk of recurrence. So surgery is really only the last step. If you can see here, that there's a neuroma at the end of what is probably the tibial nerve. And you can see it here and here. And you can see that it's probably pretty close to the bone here and being irritated. So early use of the prosthesis and early treatment makes prolonged phantom limb pain less likely. Prostheses may increase or decrease pain depending on whether they're fitted well. And musculoskeletal pain due to altered biomechanics is important to remember. Sensitive stumps might require altered prosthetic prescriptions like silicone liners or thigh laces, and stump bandaging and hard casting straight after the surgery can reduce pain by limiting edema. So it should be pretty standard that when you have an amputation, you wake up with a plaster around the end of your stump. So what's the treatment of phantom limb pain? Well, generally, we follow neuropathic pain principles. So we use non-pharmacological treatments, tricyclic antidepressants or selective noradrenaline reuptake inhibitors. So that's duloxetine, venlafaxine or desvenlafaxine. For tricyclics, I often use amitriptyline as the standard, but Nortriptyline is least anticholinergic. We use anticonvulsants, particularly the gabanoids, pregabalin or gabapentin, but you can use epilim, and which is valproate or carbamazepine. Lignocaine patches can sometimes help if there's local tenderness. Opiates should be avoided, and interventions are really only used to get people out of the emergency department or at very significant times. Non-pharmacological treatments, well, prosthetic modifications, unload or recess or refit the prosthesis to avoid the painful area. Cognitive behavioural therapy is quite good, teaching people how to put up with their pain. Desensitisation of the stump. Mirror box treatment is used, although the theory behind it seems a bit questionable, that somehow changing the brain's appreciation of the size of the limb or the movement of the limb will bring some sort of analgesic effect. The studies are small. There's no really large randomised controlled studies. But an exercise and a focus on quality of life increases employment status and also improves quality of life for those who have to live with either stump pain or phantom limb pain. So again, these are the potential drug treatments, and unfortunately many of it doesn't work. So there's no evidence that epidural anaesthesia at the time of the amputation works. There's no evidence that tricyclics work, but they do work for neuropathic pain, and the numbers needed to treat are 3.6. SNRIs do also work, but the numbers needed to treat are higher, 7 to 8. Anticonvulsants work, but their numbers needed to treat is about 5 to 7. And opioids do work, but the numbers needed to treat are 4.3. And it does not seem logical that opioids could work. Intrathecal opiates or lignocaine, there's poor evidence for. IV ketamine, capsaicin, lignocaine patches, also all very poor evidence. Sympathetic blocks do not work. There's also a fairly high risk of complications. So what are the potential interventions? Sometimes a periradicular block can be helpful if the pain, phantom limb pain or stump pain, is coming from a compressed nerve root. Sympathetic blocks don't really work. Dorsal column stimulators do not work. Deep brain stimulators do not work. Vascular bypass can work if there's claudication as a major problem. So that's, a bit of food for thought. Makes you think, have we come very far? So the evidence around it is pretty poor. So there's no strong evidence for any treatment. And this was in a randomised controlled study in 1980, another one in 2002. But there's very few systematic reviews since that time. In these ones, the epidural anaesthesia didn't work. Early trials looked promising, but two small cells were inconsistent. When they did a better trial, they didn't show any benefit. Regional nerve blocks, sciatic or posterior tibial, short-term pain relief only, and so that would be only a matter of a day or two. Intravenous ketamine does not work for phantom limb pain. Intravenous salmon calcitonin, there was one study that showed 76% were pain-free at 1 week, but there was no follow-ups, so we don't really know. TENS machine showed less pain at 4 weeks, but no different at 12 weeks. So Farablock, which is a metal threaded stock, had one trial, but it wasn't seen to be that beneficial. Ketamine infusion have not been shown to work. There was one study in ketamine that showed it to have a modest short-term effect, but none of them lasted. The amitriptyline is well documented for neuropathic pain, but when they did an RCT in 2004, it had no benefit. Gabapentin, again, quite well tolerated, but an RCT did not show any benefit. An RCT in phantom limb pain showed a benefit at 6 weeks, but it didn't sort of follow it up after that. So we don't know whether that would be of any benefit at a later point. So far, that's the only thing that seems to work in the short term. Botulinum toxin was used in a randomised controlled study, wasn't found to be of any benefit. Some of the biologicals were tried, but again, this didn't show any specific impact. And memantidine, which is an NMDA blocking drug used in Alzheimer's disease, showed no improvement. So then in 2014, they showed that the best evidence, which is level 2 evidence, which is a single randomized controlled study, exists for the use of IV ketamine and IV morphine for a short-term perioperative period of both phantom limb pain and oral morphine for an intermediate to long-term effect. There's level 2 evidence is mixed for the efficacy of perioperative epidurals with morphine and bupivacaine for short-term pain relief, as well as for the use of gabapentin for intermediate. So again, none of the evidence is very robust. So what are the non-drug treatments? Cognitive behavioural therapy, exercise, but we don't know which type, or mirror box evidence. And why is it so hard to get evidence for the treatment of phantom limb pain? Because there's a low amputation rate. It's about 24 to 27 per 100,000. People are surviving for longer. And if we had a look at Halbert, their study in 2022, they rejected 174 out of 186 trials because of the poor methodology. So it was only small numbers of patients in all of the trials. So there was a study done in 2020 to see whether osseous integration, which is the putting of a metal rod extruding through the skin for the direct attachment of the prosthetic, would decrease phantom limb pain, but the results were unclear, and the methodology was questionable. Then there is evidence that there is modification in the motor cortex and the cerebellar grey matter and white matter, but what is the meaning of it? We're not certain, except that we know that the brain does alter. And there was a study of virtual reality that showed that there was no significant role in phantom limb pain. So a reduction in phantom limb pain has actually improved because of surgical techniques. So there's 2 surgical techniques that may be helpful. One is the nerve transfer, and what happens is you take the cut end of the nerve and you transect it or graft it onto an existing nerve that supplies a part of the transected muscle. So the muscle's innervated, but the muscle's cut in half, and you find the nerve supplying the muscle that is going to be kept and inside the stump, and you graft the cut nerve onto the nerve supplying that muscle. So that's TMR. The other is wrapping the nerve ending in a piece of grafted muscle. So what you do is you take a piece of muscle and you wrap the nerve ending into it. Now, there's been 2 systematic reviews. Both of these techniques can be primary, that's involved in the amputation at the time and prevention, or they can be secondary and being used to treat neuromas. So in 2 of the randomized controlled studies, it showed that either of these techniques, surgical techniques, could improve phantom limb pain, but it would definitely improve residual limb pain. But it may or may not decrease the neuroma incidence. A year later, another retrospective study was done with 17 studies, one of them an RCT, and it showed that it can decrease overall pain with 50% of people complaining of pain compared to 70 to 80% of people. And a secondary treatment, this is for people who had a neuroma and then they were operated on to either graft the end of the nerve onto an existing nerve or bury the neuroma in muscle, did not show really clear conclusions and said it required more studies. So in summary, take a history. Examine the patient. Is it stump pain or is it phantom limb pain? Is it any other cause? Is it a central cause? Have they had a stroke? Is it a spinal cord? Is it a nerve disc? Is it complex regional pain syndrome with pseudomotor changes? Or is it a brachial plexus or lumbar plexus injury? Is there any associated psychological problems? Is there depression or anxiety? Nothing works, so you should try things in a trial setting before you go on, and you might strike it lucky. So what that means is try a drug for, say, 3 or 6 weeks, ask them to measure their pain, then stop the drug for 3 to 6 weeks and ask them to measure their pain, and then restart the drug for 3 to 6 weeks and get the patient to measure their pain, then look at the pain scores, and if they're definitely decreased when the patients are on the drugs first time and second time, then you're winning. And if the pain scores are up when they're off the drug, you sort of got evidence that you should try and use that particular drug. So remember that pain is subjective and it can't be seen. So take a pain history, listen to the descriptors, take a functional history, make sure you know what the patient is able to do in activities of daily living. Take a past history, particularly drug history, so that you're clear as to whether there's been any drug and alcohol issues in the past, and note some of the passive coping styles. There's a lot of people who want everyone to look after themselves, don't want to really contribute to their own care, and some of them are very fearful to move. So examine the stump, examine the joints if they go OA, they've been traumatised, examine the bone, look for infections or fractures, remember osteoporosis, check the skin, is it warm? Is there a colour change? Is there atrophy? Is there a scar line? Is there edema? Do a neurological examination. Is there allodynia or hyperalgesia? Is there a peripheral neuropathy? If there's reflexes, are they present? Have a look at the limb from a vascular point of view. Is it cool? What are the capillary terms? Is there necrosis? And then look at the gait. See if there's pumping into the stump socket. Look for anxiety. Look for the face, for wincing when they walk. Check the prosthesis. Is the wear uneven? Is it too loose or too tight? Check the number of socks used, and also if they're using any tissues or rubber bands or anything like that to improve the fit. And watch them put their prosthesis on and off. So history, examination. Is it stump pain? Is it phantom limb pain? Is it something else? Is there an associated problem? Nothing works, so you need to try it. And my last question is, what's the world's most common cause for amputation? Anyone have any plans, ideas? Put it in the chat. So it's essentially landmines, and 2,000 are killed or maimed every year, mostly children. There's 12,900 prostheses made by the International Red Cross in '94, but there's 25,000 amputees, 250,000 amputees registered with the International Red Cross. The cost of an amputation, cost of a prosthesis is about $3,000 per amputee, but it only costs $3 to buy a landmine. And if there are still 110 million landmines in 64 countries. And the number of prostheses parallel the number of mines. So it's a long road if you've got an amputation, and there's a long road to treating them. I hope this report, this presentation has been of some benefit to you, and I'll be happy to take questions online. Please feel free to put the questions in the chat box, and I'll try and answer them online in the next few days if they're sent to me. Thank you very much for speaking with me or listening to me today. I hope I've been of some benefit to you.